Respiratory 103 Chapter 2. Ventilation is the movement of gas between the external and the alveoli. O2 goes into the alveoli and CO2 comes out of the alveoli. The primary principle of ventilation is the pressure gradient and differences. If alveolar pressure is low, then high barometric pressure goes in. And if alveolar pressure is higher than barometric, then air goes out. Driving pressure is the difference between 2 points. Atmospheric, also known as barometric pressure, is measured by a mercury barometer. The equilibrium point is when lung pressure is equal to atmospheric pressure. This happens at the ends of inhalation and exhalation. Transrespiratory, also known as transairway pressure, is the difference between barometric and alveolar pressure, which is responsible for our breathing. Transmural pressure is the difference across the airway wall. Transpulmonary pressure is the difference between alveolar and pleural pressure, and alveolar is always greater than pleural pressure. Transthoracic pressure is the difference between alveolar and body surface pressure, which is very similar to transrespiratory pressure. It is responsible for expanding the lungs and the chest wall in tandem. Lung compliance. The average is 0.1 liters to cm of H20. Decreased compliance causes lungs to stiffen, respiratory rate goes up, tidal volume goes down, and the volume pressure shifts right. Increased compliance causes elastance to go down, it's easier to breathe, and volume pressure shifts left. Airway resistance is the difference between airway and alveoli pressure divided by the flow. It causes friction. And the normal is 0.5 to 2.5 centimeters of H20 per liter per second. Time constants are the result of lung compliance and airway resistance. If either one decrease, so does the time. They are defined as the time it takes for a lung part to fill to 60%. Anatomic dead space is the volume of gas left in the conducting airways. Alveolar dead space is when the alveoli is ventilated but not perfused. Physiologic dead space is the sum of anatomic dead space and alveolar dead space. Pulmonary surfactant is made and stored in alveolar type II cells. It is made up of 90% phospholipids and 10% proteins. DPPC is the primary chemical and surfactant that lowers surface tension. 3 classes of flow are laminar, which is streamlined due to a low flow rate and low pressure gradient. Turbulent is random because it usually encounters resistance due to its high flow rate and high pressure gradient. Tracheobronchial, also known as transitional, is the combo of the two which occurs at the carina. Normal ventilation has a tidal volume of 5 to 7 milliliters per kilogram or 3 to 4 milliliters per pound, with an average of 500 milliliters. A ventilation rate of 12 to 18 breaths per minute, with an average of 15. And an I/E ratio of 1 to 2. Respiratory rates of different age groups. 0 to 1 year have 30 to 60 breaths per minute. 1 to 3 have 25 to 40 breaths per minute. 3 to 6 have 20 to 35 breaths per minute. 6 to 12 have 20 to 30 breaths per minute. 12 and up have 12 to 20 breaths per minute. Breathing conditions include apnea, which is no breathing; eupnea, which is normal breathing; hyperpnea, which is deep breathing; tachypnea, which is fast breathing; orthopnea, which is only breathing comfortably when sitting upright; and dyspnea, which is difficulty breathing. 5 abnormal breathing patterns are biotes, which is short episodes of rapid uniform deep inspirations followed by 10-30 seconds of apnea, and seen in patients with meningitis. Hyperventilation, which is increased alveolar ventilation that causes a decrease in CO2. Hypoventilation, which is decreased alveolar ventilation that causes increased CO2. Cheyne-Stokes, which is a gradual increase in volume and frequency followed by decrease in volume and frequency of breathing followed by 10-30 seconds of apnea. It is common with cerebral disorders and CHF patients. And Cushmall's, which is an increased rate and depth. Common during ketoacidosis and diabetics. Clinical connections. Inspiratory intercostal retractions is when tissue moves in between ribs called intercostal, above the clavicle called supraclavicular, or below the rib cage called substernal. It is more common in infants than adults, especially preemies. It is a key sign of RDS. Tension pneumothorax from PPV. Signs to look for are diminished or absent breath sounds on affected side. Increased heart rate. Trachea shifting to the unaffected side. Decreased blood pressure. Hypersonant percussion over the pneumothorax. And displaced heart sounds. Pulmonary surfactant deficiency is common in preemies with RDS. This is because preemies are born before their type 2 alveolar cells mature enough to produce adequate surfactant. If untreated, it will cause atelectasis, which then must be treated by refilling the lung with a CPAP and giving a surfactant. In restrictive lung disorders, lung compliance is decreased, which leads to time constants being decreased. It causes high respiratory rates and low tidal volume. Seen in patients with atelectasis, pneumonia, pneumothorax, pleural effusion, pulmonary edema, ARDS, and interstitial lung disease. In obstructive lung disorders, there is increased airway resistance, which leads to increased time constants. It causes low respiratory rates and high tidal volume. It can be seen in patients with asthma, chronic bronchitis, emphysema, and cystic fibrosis. Autopep is caused by inadequate expiratory time, leaving air behind. It causes increased work of breathing and is common in obstructive disorders. Formula time. Boyle's law we all should know. P1 times V1 equals P2 times V2. If pressure increases, then volume decrease. This is the formulas she expects us to know, so good luck with all that. Respiratory